So I will continue as the fourth speaker. I'll share my screen. I have asked Ignacio Fuentes, the program director of the J Clinic, to help manage the questions. Ignacio, can you see my screen?
Absolutely, I can see it. Thank you, Dimitris.
Thank you. So the presentation is a body of work on summarized in a website called covidanalytics.io on predictive and prescriptive analytics for the pandemic. So first, I would like to acknowledge the contribution of the exceptional young people we have at MIT, without of whom I would not be talking today. There are too many to talk, but it's about 25 doctoral students in my group. So I have prepared to talk to you briefly about three efforts: an epidemiological model that is currently part of the CDC models and is utilized today for assisting a large pharmaceutical company orienting its efforts on where to do the trials. Then a hopeful message on what happens if we have a vaccine available, how do we allocate the vaccine so that we maximize the effect, minimize the number of deaths, and then some clinical scores that are currently in use in some of the hospitals that we have been collaborating. So the first is a presentation on Delphi. So Delphi refers, of course, to my Greek origins, but also is the acronym for differential equations lead to predictions for hospitalizations and infections. So as a background, accurate predictions are critical for almost all important questions regarding the pandemic. However, such predictions are quite involved, as there are several characteristics of data sparsity, human intervention. Governments, of course, change policies all the time, and there's parameter sensitivity as well. So what we'd like to do is we have developed first through the team, we developed a lot of data from publications regarding from both clinical and also epidemiological that we utilize. So the model we utilize, and this is sort of the epidemiology 101, is a compartmental epidemiology model in which the succession of the disease is from susceptible people to exposed to infected and then recovered. We augmented this model by accounting for the underdetection that exists and also modeling societal response through nonlinearity. I'll talk more about that. So our model involves, again, susceptible, exposed, and infected, but far more detail on undetected people, hospitalized, and quarantined. The time does not allow me to go into multiple details, but this is a system of nonlinear differential equations that are parameterized by some parameters, some of which we detect from data by solving an inverse problem. I will tell you more about it, some of them from publications. A key component, perhaps the most important, is in this extended formulation is the constant rate alpha, which can be regarded as the average number of people each infectious person would infect per day. The classical model assumes a constant infection rate. However, given social distances, mask wearing, and stay-at-home orders, the way we have chosen it, and this is critical for the success of the model, is to have a nonlinear component given by this formula. But rather than formulas, let me explain it pictorially. So, and this is also trying to capture first and second and multiple waves, not only the first wave, which and in many environments we are in a second wave environment, some of them even in a third. So the initial phase, phase one, is the initial response where the population awareness is relatively low. So, so people, the infection declines, but not very sharply. Phase two, we observe a sharp decline in infection rate as policies to control the spread go into full force, and the society experiences shock event. Phase three, this part, is saturation of the policy effect, representing by the diminishing marginal returns, which is the decline of infection rate. And then phase four is a resurgence in case, by a certain multiple that is reflected in the equations, due to the fact that people relax governments as well as people relax restrictions and behavior changes. So what we do, therefore, is from public data, and we do this for all the states in the United States and about 120 countries. We change our model daily. And in many cases, we also go into the states of various countries that have asked us for example, various governments around the world have asked for some help, and we have provided that. So, but key here is that some data exists, for example, total detections, recovered patients, deaths, and hospitalizations. And from that, we infer parameters that we adapt to the location we try to predict. And the way we do it is that we solve a problem that over the parameters such that we have the best possible fit. Overall, the model has been operational from the beginning of April. And it has held its own. So these are predictions that made 3rd of April and versus historical. We were off by a few percentage points, 5% or so. From June until now, our overall rate, 45 on deaths, it's less than 10%. On cases, depending on the region, we have been more or less successful. In terms of world predictions, also over multiple horizons, our overall accuracy is of the order of 8% or so, and on deaths, maybe about the same. In terms of the comparison with some of the leading models, the models I have here are the models that the CDC is utilizing. Our model is on blue. We are, I would say, a strong performing model that has held its own, especially in environments where there has been a second wave, and in some cases, even a third one. The way we have modeled the government response, so in our website, we have the ability for governments to experiment with various policies. For example, having no measure, restrict mass gatherings in businesses, stay at home, and so forth, total lockdown, in other words. And the way we do it is we have historically, and in each region, have found that if you take no measure, the infection rate, let's call it 100%. If you start increasing the measures, we have found that the infection rate that works well in our equations declines, and these are the percentages it declines. For example, lockdown is, the infection rate decreases from 100 to 24%. This allows us, of course, to create what-if scenarios, and here's a rather dramatic one. So our model suggests that if we started the lockdowns a week earlier in the United States, in New York, for example, who has the biggest effect, the total number of deaths would have declined by about 80%. That's a very significant number. That shows how nonlinear the disease is and how even 1 week can make a difference. Similarly, Switzerland, for instance, is in the same environment. So then now we have a model that can predict over time how the disease will evolve. Then what we have observed, now suppose we have a vaccine available, which we all hope for, and I think it's realistic at some point in the future, we will have a vaccine, not perfect, but maybe let's say 60 or 70% effective. The question is how to allocate it. And there are some observations that we have, that the world has made, that mortality rates depend on age in a very significant and nonlinear way. For example, the mortality for 80-year-old patients is close to 15% versus a very small percentage, less than 1% for people between 10 and 49, and then it increases after that. In addition, the infection rate among various countries, various states in the United States varies significantly. For example, nowadays in the Northeast, which used to be in the early parts of the pandemic in particularly bad shape, it's in a better shape compared, for example, to the Southwest in the United States. So the question is, what is the idea? How can we have a principled way for allocating vaccines? So we developed an optimization model that tries to minimize cumulative deaths. We have the dynamics of the Delphi model that basically tells you how the disease will evolve. We also have, of course, resource constraints, namely that the vaccines are in limited supply, and there are also fairness requirements. You cannot, and fairness would be among states, among ages and so forth. And we also have limitations, how effective the vaccine is, safety requirements, and so forth. By the way, all of this material can be found, the papers and experimenting with the software can be found in the covidanalytics.io website for more details. So when we put everything together with a hypothetical, let's say we had a vaccine on July 15th, and we had, let's say, 300,000 vaccines per day available. So compared to a random allocation, that would be, of course, the most fair way to one could argue that by basically vaccinating people that are most likely to infect others, this is the key idea of the problem, we can actually decrease compared to random. This is in simulation. This is not in reality, of course, because we don't have yet a vaccine of that level. That there will be a significant improvement in deaths reduced by 20%. So, so given that in the audience there are also people that might represent the government, I would also say that thinking about how to optimally allocate vaccines, especially in the beginning, that they might not be in fantastically high availability, might actually save significant lives. That's my key message on the second part of my presentation. The last part of my presentation is on clinical risk scores. So we utilize machine learning to predict patient outcomes and facilitate triage decisions. So specifically, we have focused on mortality, presence in the ICU, and also infection. And the way we have utilized it is that we have collaborated with many hospitals around the world. We have about 44 hospitals and about altogether more than 10,000 patients. In the beginning, the collaborating hospitals were from Italy and Spain, then in the United States, and now from Latin America as well. We have about, as I mentioned, 44 hospitals, about 10,000 patients. And our process is as follows. I will detail briefly two calculators. So the first calculator is try to predict mortality. The reason this might be relevant is how to allocate resources, especially in an environment that the resources are not fully available. So as an example, our first model, we utilized of the order of 3,000 patients from Cremona, Italy, and Spain. In that population, these were early stages in the disease. The mortality rate was high, about 25%. And we utilized demographics, comorbidities, vital readings, and lab values. Lab values are optional. We developed a model quite accurate, I would say, boosted methods. And with lab values, the mortality calculator was 96%, and without lab values, 92%. The method also is able to find what are the most important values, parameters that affect prediction. So age, BUN, oxygen saturation, and so forth are quite relevant. We also had an infection calculator that also is reasonably accurate. This can be done without lab values over the phone from your home. Of course, the accuracy is not fantastic, but it's 83 AUC, area under the curve, and accuracy is similar. It's about 83%. If you have lab values, so you do a blood test, a regular lab test, the accuracy becomes higher. So these models, the mortality model is currently being used in some hospitals that have a reincarnation of the disease, unfortunately, and therefore is used for triaging methods. And the infection is currently utilized in environments where people call whether to come to work, and this is a very easy way to do it. We have publicized the calculator that they can use for assessing themselves whether to take a test or not.
Dimitris, sorry interrupting you. We're now in the 5-minute Q&A. I think it's fascinating, and maybe you can elaborate a little bit more on the risk scores.
On the risk scores, key here is that we identified, and you can actually experiment with on the website, the calculator is available. We have found that what people reported in the literature, we have also found it from the medical data. But in combination, especially the mortality calculator, which is quite accurate actually in the 90s, has been used effectively for triaging decisions. So altogether, I would say the effort of the group So that the combination of our expertise in AI and optimization could, we hope, help in combating the disease. And I'll be glad to open it to questions.
So I was looking at this. I would be very curious if some members from CDC would be also interested on the idea of the super spreaders. I think that that could have a huge impact. I'm looking for the questions now, but if you want to elaborate a little bit more on this, I think this is something that would be very appealing to audience.
Yeah, so the optimization question, the allocation of vaccines, this is not, of course, applied because we don't have a vaccine, but it's a conceptual idea that thinking about, and this is a complicated story. There are issues of fairness, there are issues of limited resources and so forth. But given that we have a reasonably accurate model for prediction, it makes sense to me that to try to identify spreaders earlier on in order to have a long-term effect on the allocation. That's the logic of the presentation.
Okay, I don't have.
There are some questions. I would say mortality can vary greatly depending on how overwhelmed the healthcare system is. Does the model account for this? Indeed, it is the case. For example, the model I told you about the COVID-19 is from data from hospitals in a significant in the area of the disease in the early March, that it was pretty bad. We have also applied it in other countries with data from other countries where the severity of the disease is much lower, data from the summer, for example. So we have to adapt for the environment we are in. But once we do it, machine learning learns quite well. It does learn, as the name suggests. And while not perfect, is, I think, quite usable in many environments that I have seen.
Yeah, there's another one here. How would it be possible for government representatives to test the vaccine optimization model with their own data?
Yeah, I will be. Our model, the codes are available, publicly available in our website. Of course, I will be glad to help, and my group will be glad to help. But we'll be very glad to provide our optimization model, our papers. You know, everything is public domain, and our time also is available to help.
Single dose versus double dose impact on with the timeline?
Single dose, yeah. So at the moment, this is a conceptual model that takes into account the single dose, but it's possible to modify the model to also consider double dose. We know many of the pharmaceutical companies that are involved in these trials have both single and double dose trials. The model I briefly described is single dose.
If you mention about the vaccine hesitancy and if the model accounts for this?
It does not at the moment. It does capture the fact that we parameterized it. We say it's 60% effective, 70% effective, 50% effective, and the policy is actually different. But the hesitancy is not taken into account.
Okay, so I would return now the floor to you, Dimitris, as session chair, and maybe we can continue with the.
Thank you very much.
Thank you.